Okay, good morning and good afternoon to esteemed officials from the Ministry of Health, line ministries of the member states, WHO country office colleagues, supply chain professionals from the partner agencies, academia and private sectors supporting the response to COVID-19 pandemic. On behalf of WHO Regional Office for Southeast Asia, I would like to thank each and every one of you for being here with us today for this webinar workshop on waste management of COVID-19 commodities. Um, the outbreak of COVID-19 is far more than a global health crisis. It is affecting our societies, our economies, and has had a deep impact on our everyday lives. And then waste management is no exception. The massive use of the PPE items such as medical and N95 mask, gloves, gown, etc. Since the onset of this pandemic has led to enormous increase in medical and hazardous waste generation. In addition to, with the kickoff of COVID-19 vaccines has led to growing challenge of biomedical and waste disposal in many countries. Countries are simultaneously fighting against COVID-19 to contain the spread of the virus, while at the same time preventing risk to the environment and human health caused by the COVID-19 related waste. To protect the human health and environment, it is vital to ensure that the safe um, to save the safe environment and as well as to the human health. So today's workshop is being organized by WHO CRO in partnership with the Goan and Empower School of Health. And the main objective of this workshop is to address some of the issues and challenges related to the waste management of vaccines and non-vaccines health commodities in response to COVID. So for today's workshop, I would like to introduce the facilitators, starting with Professor Andy Barklov, Director of the Learning and the Development from the Empower School of Health, Mr. Sakshin Jagtap, Head of Supply Chain Consulting also from the Empower School of Health, and Dr. Sudhir Khanal, Technical Officer in Immunizations and the Vaccine Development Unit from CRO. And then lastly, but not the least, Dr. Victor Del Rio Villas, who is the technical officer for the Global Alert, Outbreak Alert and the Response Network from CRO. In the interest of time, I would like to request all the participants to introduce themselves in the chat box and also request the participants to mute their mics and raise their queries in the chat box. And then we will try to address and answer them as many as possible within given the time frame of during the workshop. For all unattended queries, we'll try to get back to you at the earliest after the workshops and try to answer them. And once again, I would like to express my sincere thanks to all the participants for your valuable presence today and looking forward to your valuable inputs and then proactive participation during the workshop. Thank you. Over to you, Sakshin.
Yeah, thank you, Dr. Hyun, for setting the tone for this webinar. Now I will invite Dr. Sudhir Khanal from the IVD Department of WHO CRO to come and take us through his presentation on COVID vaccines. So now that almost all countries in the CR region have started, and the others will probably expected to start soon with their vaccination program. So while we face many challenges in terms of getting the program rolling on the ground, managing the logistics, we have to also at the same time start managing the waste which is coming from vaccines. So Dr. Sudhir today will not only take us through an update on the vaccine rollout, but also give us valuable guidance on how to manage the vaccine waste. So over to you, Dr. Sudhir.
Thank you very much, Mr. Sachin. And good morning, good afternoon, and good evening, everybody. Somehow I cannot start my video. I cannot open my camera, but I think it's okay. Uh, are my slides visible? If somebody could confirm.
Yes, Dr. Sudhir, your slides are visible and your audio is also clear. Please go ahead. Thank you.
Yeah, thank you very much. So once again, good morning, good afternoon, and good evening, colleagues from different parts of the world. I see a number of participants from outside the WHO Southeast Asia region, while I'll be focusing more on the WHO Southeast Asia region. Uh, I'll be basically talking about COVID-19 vaccine development updates, what has been the deployment in Southeast Asia region and the vaccination rollout, and about waste management in WHO Southeast Asia region. So I have 4 components to my presentation. I'll start with the first one, COVID-19 vaccine development updates. As you know, COVID-19 vaccine has been developed in rapid phase, and this is very unprecedented. As of today, we have at least 81 candidate vaccines in clinical trial, and 12 are already in use. So this slide shows you what are the platforms that have been used, and we have at least 10 platforms for COVID-19 vaccine development. Some of them are conventional platforms, um, while others are very new platforms. And we have 12 vaccines, 5 vaccines developed as a non-replicating viral vector platform, 4 vaccines using inactivated virus, 2 vaccines using messenger RNA, and 1 vaccine using protein subunit. And, and 12 vaccines are currently being used by countries. Some of them have been emergency use listed by WHO, like the Pfizer vaccine and the Oxford AstraZeneca vaccine and the Serum Institute of India Covishield vaccine, where others have been approved by stringent national regulatory authority for vaccines like the FDA, and some have been, others have been approved by other stringent national regulatory authority. And a significant number of countries have, you can see in the slide, approved vaccines. Like Pfizer vaccines have been approved in 68 countries for use, Moderna vaccine in 40 countries, Gamaleya vaccine, Gamaleya, the Sputnik V vaccine developed by Russia, is approved in 45 countries, Oxford AstraZeneca in 74 countries, Serum Institute vaccine Covishield, which is again manufactured in India, but in line with Oxford AstraZeneca, is approved in 17 countries, and so on and so forth. And the cold chain requirement for these vaccines, most of these vaccines require cold chain of 2 to 8 degrees centigrade, which is a welcome news for all of us working on immunization logistics, because this is what we regularly have for the routine immunization system. Some vaccines require minus 20 degree and others require ultra cold chain like minus 70 degrees centigrade, which the routine immunization system is not used to. And for the logistical purpose, it's also important to know how many doses are required for each vaccines. So most of the vaccine require 2 doses, but Janssen is a vaccine which required 1 dose, but there's also a study going on for 2 doses, and CanSino vaccine requires 1 dose. And the dose gap is also important for us as immunization logisticians to plan for the vaccines, because these vaccines come with very short shelf life, about 3 to 4 months of short shelf life. So it's important how we plan deployment of this vaccine. Most of them have a gap of 3 to 4 weeks, but then we also have Janssen, which does not require second dose, but if second dose is given, should be given in 8 weeks. Some require three weeks, like the Pfizer vaccines require gap of 3 weeks between 2 doses, and Sinovac vaccine requires 2 weeks, others are normally 4 weeks. Looking into the price of the vaccine also depends on the economy. The high income countries pay high and the low income countries pay low, but I'm giving you a sense of the pricing. Pfizer vaccines are available in between $6.75 to 19.50 US dollars. Moderna vaccines from 15 to 38 US dollars. Gamaleya for 10 US dollars outside Russia. Oxford AstraZeneca is available at $2.19 to $5. The Serum Institute vaccine is available from 4 to 13.27 US. The Janssen, which was recently approved by Food FDA in the US, comes at the price of 8 to 10 US, and so on and so forth. And looking at the vaccines that these are the vaccines that are already in the market, but there are also a number of vaccines that are still in clinical trial. And they are of particular interest to us because a number of them are of one dose, at least 12 of them are of one dose, 2 of them are of 50 of them are of 2 doses, and there's also one vaccine for 3 doses. And especially the route of administration, we definitely would like to have an oral vaccine, but we don't have them yet. We only have injectables, but there are research and development going on, and 2 vaccines that could be given orally are on clinical phase trial, and 68 injectable vaccines are other injectable vaccines are in clinical trial. Some of them are subcutaneous, others are intradermal, and some are intramuscular. Most of them are intramuscular vaccines. So this is on the update on vaccines under development, landscape under development. The next I want to take you to is on the COVID-19 vaccine deployment. For the deployment of COVID-19 vaccine, all countries, at least 92 countries that were enrolled with the COVAX facility. I'm sure a number of you are already aware of what is a COVAX facility. If not, it's a consortium of many organizations, WHO, UNICEF, Gavi, CEPI, and other partners, to pool in vaccines for fair and equitable allocations to all the countries irrespective of their economic status. So the COVAX facility had requested for a national deployment and vaccination plan, and all countries in the WHO Southeast Asia region have developed a national vaccination and deployment plan. And these plans were reviewed by independent experts. And these plans contained at least the following 9 components, which were explicitly mentioned on the regulatory preparedness status, and if the country was ready to welcome the vaccine, if the regulatory processes were in place, if the country had done a prioritization of target population based on the vaccine availability, and if there were any planning or for coordination and service delivery strategy, costings and funding, supply chain and waste management, human resource, capacity building and training, demand generation, vaccine safety and vaccine safety surveillance and monitoring and evaluation. These are the components explicitly mentioned in the National Deployment and Vaccination Plan, which we call them NDVPs. These NDVPs were the basis for allocation of vaccines by the COVAX facility. However, in the review, we also saw that there were at least 3 areas where countries needed to strengthen their NDVPs: costing and funding. While countries knew where the funds and costs were coming, but they had not explicitly mentioned this in the plans. Waste management was a particular area that needed significant attention, and there was no elaboration in the plans on how immunization waste management would be done. And the third component was demand generation. So today we will be talking a bit about waste management. I would not claim to cover the entire waste management on immunization, but some key principles on immunization waste management will be shared to you today. And I'm sure we will hear more from your experience and lessons learned also as part of cross-learning. So based on the NDVPs, vaccines were allocated by the COVAX facility to the country. The COVAX facility aims to vaccinate 20% of the total population of the countries, 92 countries that were enrolled into the COVAX facility. From the Southeast Asia region, except Thailand, all other countries had enrolled to the COVAX facility, and the COVAX facility in multiple tranches would give 20% vaccine required for the 20% of the population. So for the first tranche, there was a letter to all the countries on 26th of February, where they indicated what were the doses countries would be receiving by the end of May in 2 shipments, and they also mentioned what were the delivery expected for in the first shipment by the countries. Countries also received a number of vaccines in donation, especially from Government of India as part of their vaccine diplomacy or vaccine maitri, they call it. Government of India supplied Covishield vaccine, Oxford AstraZeneca vaccines developed in the Serum Institute of India to at least 6 of its neighboring countries, friendly neighboring countries. And then countries also had bilateral agreements, and these are the number of doses. The last column shows you the number of doses received by the country as part of the bilateral agreement. These are indicative doses and picked up from different media news, but not confirmed by the governments yet on the bilateral agreement. But the COVAX facility doses we actually know. This is important for us to know because these vaccines come with very short expiry. Most of them expire in April, and some of them expire in May. So it's important that we use them early and ensure that the logistic plans are in place for that. The, After the deployment, I'd like to talk about the vaccination status. So the vaccines have been deployed in the country. Have the country started vaccination? And what is the status as of today? So at least 9 out of 11 countries in the WHO Southeast Asia region have started COVID-19 vaccination to its first priority group. And for most of the country, the first priority group is the health workers and the frontline workers. And the first country to start in the region was Indonesia, and the last country to start was Thailand. Some countries are using multiple vaccines for multiple manufacturers, which is again important from the logistic point of view because we don't know about the interchangeability of the platform. If a person has received one vaccine, the first dose with one manufacturer, the second dose should be of the same manufacturer. So it's important to logistically manage that also. So as of today, at least 36 million doses of vaccines have been administered in the WHO Southeast Asia region. 30 million as first dose and around 5.8 million as second dose vaccine. And this is how it looks in a pictorial form. Maldives has vaccinated around 31.5% of its population with the first dose, and Nepal has vaccinated with 4.2% of the population with first dose, followed by Sri Lanka, Bangladesh, and India, Indonesia, Thailand. So a total of 1.5% of the total Southeast Asia population have been vaccinated with first dose of COVID-19 vaccine, and around 0.3% with two doses of complete doses of COVID-19 vaccine. And you can see the proportion of vaccines that each country wear. And we've also shown you timeline. So Indonesia was first, followed by India, Bangladesh, Myanmar, and Nepal started on the same date on 27th of Jan. Then Sri Lanka, Maldives, and then Thailand. So this is the vaccination status in the Southeast Asia region. We're still looking for disaggregated data by age 6, and we hope to receive them soon in the near future. So vaccinating 36, as I said, vaccinating 36 million people have generated a lot of immunization waste. And how has that been managed? Countries are used to manage immunization waste in different ways, in a small scale, only for the birth cohort of that year, but this is like the entire population. So countries will have to look into the immunization waste management. It may not be a problem initially for the first 3% of the population who have been vaccinated, but as we start vaccinating more and more population, it's going to be a big challenge. So I just thought I should directly jump into the management of waste from COVID-19 immunization campaign. Because it can cause direct negative health impacts. I don't have to tell this, but I just thought, let me reiterate that. It can cause direct negative health impacts on the community and the health personnel, as well as pollution due to inadequate treatment. Mind you, I'm talking about inadequate treatment and disposal of these waste can cause indirect health effect in the community and impact the environment. So it's important. So while there are a lot of factors on waste management, and a number of you in the webinar are experts in this area, I thought I should directly jump into some key points related to immunizations. Like what do we expect at the session site? Sorry, I can hear some people talking. If you the mic.
Yeah, can I request everyone to be on mute except for Dr. Sudhir? Thank you. Please continue, Dr. Sudhir.
So thank you. At the immunization session site, particular things that is important other than the entire package of healthcare waste management, which is relevant to the entire healthcare waste management also, but specifically for immunization session site, the waste segregation and packaging. There's a need to prepare sufficient number of safety boxes. The immunization program uses safety boxes and waste containers with plastic lining. Normally these plastic linings, the waste containers are also sometimes they also use biohazard uh, bags. It also depends from country to country. And then we expect that at the immunization center, the immunization team or the vaccinator or the team lead will work to always segregate SARS from non-SARS at the source. And immediately after use, the entire syringe with needle are discarded into the safety box, specifically designed safety box, without recapping the needles. Uh, and if the countries are using hub cutter to follow the national guidelines on how to dispose the needle with the hub that has been cut using the hub cutters. When these safety box are filled to 3/4 of its volume, normally a liter of safety box, a 5-liter safety box is used, which can carry around 100 syringes. So these safety boxes are put into plastic bags or biohazard bags, closed hermetically, airtight seal, I would like to say rather, uh, when full to 3/4, and then uh, mark the bag clearly. There are also empty vials that are generated at the session site. So the empty vials will have to be put into the waste container to avoid leakage, and different containers can be used based on the program that are providing. But at the end, they have to be sealed and marked clearly. Mm. There are also other immunization waste like the personal protective equipments, plastics, cotton swabs that should be put in a separate container. So at least there are uh, three 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 components are required: the safety box to be put in one area, the empty vials in the other, and the other immunization waste separately, and then frequent hand washing and performing COVID appropriate behaviors. um, I don't have to explain on what are the COVID appropriate behaviors: maintaining social physical distancing, hand hygiene, use of mask, all those things will have to be performed. So this is at the session site. So we don't encourage waste disposal at the session site. They are expected to be carried at the health facility, and so how to store, treat, and dispose. So we expect that the store area is always dry and restricted only to authorized people, and then make sure that no one else can access it, because we have seen that there's a lot of we have experience in the Southeast Asia region that these materials have been stolen and sold to scrappers. Uh, we also expect that protective cloths are used during storage and transportation of these materials by the handlers. For the Sops box and containers of the containers of empty and expired vials, we expect that an on-site incineration is done. Uh, we expect that the incinerator has a temperature of minimum of 800 degrees centigrade. If there is no incinerator, we also expect that burning in the drum can be also the suitable option. But open fire burning is not recommended because it cannot ensure complete disinfection of the waste. For a complete disinfection of the waste, a minimum of 800 degrees centigrade temperature is required to produce gases and residual containing little or no combustible materials. So that there is minimum creation of toxic air pollutants such as the dioxins. Basically, we want these to be incinerated, and if no incineration, burn in a drum, and then bury them. We also encourage that the empty or expired vials are crushed before burning. Otherwise, we have seen of incidents where they can explode and act like mini bombs. Um, in some countries, empty or expired vials are also treated with chemicals. They are disinfected and then recycled. Uh, and if there are no adequate treatment facility available at the healthcare facility, offsite transportation to larger facility with incinerator or to landfill site after disinfection is to be done. I think these are basic things, but I just thought we should give immunization spin to it. Some countries in the region, like Indonesia, have contracted out healthcare waste management to private sectors, where there is predefined SOPs on how these are done, and other countries, most of the country in the region is still do burn and bury, which is not in line with the national program. So there is a big disconnect between what immunization program in the countries are suggesting versus what is in the national strategy for healthcare waste management. So it's important for the immunization program, people related to immunization waste care to be cognizant of the fact and ensure alignment with the national strategy, policy and strategy. So how can we do that? How can we, so how do we set up a waste management plan? The waste management plan will have to be set up at the national level as well as at the subnational level. And a number of WHO has recommended a number of steps, like to assess the current situation and estimate the need, which also includes a number of components that have been shaded in gray in the right hand side of the screen, like to analyze the current national policy and to check if laws or bylaws exist regulating the management of hazardous waste containing, including the healthcare waste and immunization waste. Also to analyze current national regional healthcare waste management plans and technical guidelines as part of assessment. So a number of things are proposed for situation assessment, and then to define a strategy for, sorry, something has happened.
We can still see the screen.
Thank you. So maybe I'll just keep as it is here, right? So
Yeah, that's fine. Yeah.
it's fine, right? So the second step is to define a strategy for waste management, which includes to determine treatment and disposal options, whether to do offsites or when, where, if offsite, what are the possible places, to define waste transportation and central sites for waste treatment, also to outline a strategy in a document, to outline all the strategies in the guidelines that are prepared for the COVID-19 immunization activities. The third step is to allocate resource and provide materials, which is self-explanatory. This also includes allocating human resources. It's not only financial but human resource, supply of safety boxes and leak-proof containers or biohazard bags for waste packaging, uh, provide personal equipment for waste handling and treatment, and then also to build or rehabilitate any infrastructure and supply equipment that are required for waste treatment and disposal at some of the focal centers. The fourth step is basically to raise awareness and assign responsibilities. The fifth step is to set up a monitoring system to track Sops along the waste treatment until final disposal. Also to ensure a follow-up of stock positioning for vaccine syringes and safety boxes. Um, And then the sixth step is to ensure supervision during the entire process, entire COVID-19 vaccination campaign, and to carry out regular missions in the field as part of monitoring on how daily waste management practices are being done and verify all the registration procedures are happening during the supervision. And the last stage is to carry out evaluations. The most important thing in the evaluation is not only evaluating the current waste management, also to evaluate the sustainability of the strategies that are used and how this can be done in the future. Something is happening. So at the healthcare facility, again, there are a 6-step process, so which are more, well, sorry, at the national level, it's more of a strategy and national-wide macro planning, but at the health facility level, it should be more of a micro planning. And we also propose a 6-step process for that. And this 6-step process includes almost the same thing, but with subtle differences. Like the first one is to estimate the need and design infrastructure. At the local level, at the healthcare facility, the team lead or the vaccinator or the health facility in charge will have to estimate the total quantities of waste to be treated in this healthcare facility during the entire phase of the immunization activity, and to calculate the total number of safety boxes, bags, etc. required for segregating and packaging. And also they need to, if not already available, design and secure storage area for this waste, as well as for waste treatment and disposal, storage as well as for disposal. So this is what the health facilities at the local level are expected to estimate the needs and design infrastructure. The second step is to raise awareness and assign responsibilities. The third step is to develop a waste tracking system. We expect that the inventory of equipment provided are kept. There's a stock positions form for supplies, and the procedures for daily stock monitorings are in place. The fourth step is to take protective measures for staff, to check the waste operators, to check that the waste operators will wear the protective cloths. Also that there are washing facilities for personal hygiene in place, and most importantly, the safe practices for waste segregations are displayed in charts at waste segregation point at the immunization site. At least there is a job aid which displays waste segregation, and that, because people may not always remember that. And also that a response system for any accidental needle stick injury or such kind of injuries is in place, and that storage and waste treatment areas are restricted to authorized persons. These are the measures, protective measures that we expect to be taken for the staff safety. And then to set up daily routines and SOPs, we like to provide, this is the fifth step and one of the most important step, that the vaccinators should be able to know and have in hand the adequate number of safety boxes and containers for the day. They should be aware of the process for immediate disposal of used syringes, and that the needles should not be recapped. If there are hub cutters, how appropriately to cut the needles and separate the to cut the syringe and separate the needles. Also to ensure adequate segregation and airtight packaging of sops and infectious waste are done. So these are the kind of SOPs that will have to be put in place for the daily routines, and then to implement final evaluation, as I mentioned earlier. So these are the few things that I wanted to mention, and so to conclude, we can have further discussion, but to conclude, for the healthcare waste management, planning is important. The number of steps, planning at the national level, planning at the session sites, planning at the health facility, and checklist and steps that have been discussed can be helpful guide. But then everything should be country specific. Every country has their own national strategies and adaptation of plans to and the adaptation of plans will have to be done to meet the needs within the framework of the national strategy. Somebody rightly said that there is no right or wrong way for national waste management, as long as it is within the framework of the national policy and strategy. Every country have defined the strategy based on their country context, the resources available, the human capacity, the funding, and all sorts of things. And safety and protection is important. Immunization waste management um, also should ensure that the health providers and the handlers are safe and protected, while when we also protect the communities. Overall, immunization waste management is our duty as well as our right. So these are additional resources we have, and thank you very much, and happy to have further discussions on this. Thank you, and over to you.
Thank you, Dr. Sudhir. That was a very, I think, a very useful and practical presentation. And thank you for the updates. So very interesting that while we are, all fighting to solve this problem with the help of vaccines, we should not then create a second problem once we have solved this problem in terms of vaccine waste. And it was really very insightful and interesting to know how actually these vaccines, not only the volume of problem that we have, but also how hazardous it can be. Before we move to the next session, I think it would be good to take up a few questions uh, while they're fresh in our minds. And maybe, and I can already see a couple of questions. So, so one question we have from Min Nguyen, I believe from Myanmar, is that are there any tools for waste management used by countries? Is the waste tracking system the same to current systems, or it is needed to develop a new one for COVID-19 vaccine?
So do you want me to take it now?
Yes, Dr. Sudhir.
Yeah, thank you. Yes, the waste tracking system, we don't want to reinvent any wheels. We want to depend on the existing system, and we want to build on the existing systems. So if you already have a waste management tracking system, that should also be used for the COVID-19 immunization waste management. It should not be a standalone separate system. And on the tools, I have given links in the slides, and these links will provide a number of tools. There are different forms that will help to do an assessment. And those forms are available in these tools, and you could access that. I'm sure the organizers will send these slides to all of you, and you can access those links where you can have a sense of tools developed by WHO or to support assessments, as well as to assess the day-to-day need for um, in the immunization center, and what are the needs for equipments and safety boxes to and other waste disposal equipment. So those are already, I did not want to go into the details of that because of the time constraint, because this is already a 3-day long training for waste management, which I had to squeeze in 40 minutes. So I thought I just wanted to say that the resources are available. Thank you.
Thank you, Dr. Sudhir. I think there's a question somewhat related, and probably I think your answer would be applicable. Are there any minimum standards, equipments, or guidelines for on-site waste management which quantify the needs resources? I think the tools that you are referring to can help in this, but kindly confirm.
Yeah, thank you. Well, on-site waste management means different thing to different people. If you ask me as immunization person, on-site means at the immunization site, and we do not encourage on-site waste management for immunization program. We encourage that from the site, the immunization waste are taken to the health facility or to the appropriate place to manage, and the resources I mentioned are relevant for the off-site waste management. But we do not encourage on-site waste management. This is encouraged only in exceptional situation where mobile teams are far off and they cannot transport back things to the health facility or to the waste management center. So thank you, Noble.
Yeah, thank you. I think that's an important point you also mentioned in your presentation, that ideally it should not be managed on site. And a lot of compliments for you, Dr. Sudhir. A lot of people are thanking you. Any other question, or can we proceed? We will also get a chance to take up more questions later. Okay, there's one question.
Section, yeah, there was a question on the chat box.
Yes,
Um,
yes.
do we know what's the overall cost per dose that comes from the proper management of all the waste materials required for the safety administration of the vaccines?
Do you want me to take it, Sachin, or would Dr. Sudhir like to?
Yeah, maybe I can start, and then for the immunization program, immunization waste management is part of the operation cost for the campaign. I don't have an exact figure for or a ballpark or a rule of thumb for the unit cost for immunization waste management, but what we know is on an average the operational cost to vaccinate a person is from 0.6 to 1.6 US dollar, which also includes healthcare waste management, which is around 20 to 20 less than 20% of the total operational cost. This is what we have, but maybe Professor, you would be able to answer more on that.
Of course, we don't have any data for COVID vaccination yet. But if we take EPI vaccination as a guideline, then generally we believe that the waste management cost is around 2 to 5 cents per dose. It's a very crude guideline. It varies massively on the volumes undertaken, but it does at least provide a working benchmark to go forward. Does that answer the question?
Yeah, I think that would. So we have a few questions, I think, quickly. So there's one question from Terence, and maybe Professor Andy, you can, because that's more general. And he wants us to clarify the disposal of ashes from incineration from the hazards.
Right.
So
it depends what you are burning, how you are burning it, what temperature, and everything else around the incinerator. It's very difficult to give a general answer to that. Overall, the ashes would go to landfill, but in some cases, you may need to immobilize them by fixing them into materials like concrete. It depends just what you're burning and the temperatures and all the operating parameters involved. But there's no straightforward, simple answer.
okay, thank you. Then there's a question from Oliver. Has WHO given any thought as to how to advise suppliers of publicly used equipment such as masks? Obviously, the present system worked when there wasn't a global pandemic. So I think the question would be for WHO, Dr. Sudhir.
Yeah, I don't know if this is talking about the quality of the equipment or disposal of the used equipment. So it just says that how to advise suppliers of publicly used equipment. So we have pre-qualifications and we have standards, and there's a pre-qualification website that talks about all these things for the publicly used equipments. So I really don't know what is the question, but what I wanted to add to the previous questions are immunization waste disposal is not a one-time event. It has to be planned at least 3 to 6 months before the vaccination campaign starts. So for the next round of the COVID-19 vaccination, countries will have to start. They're already late, I would say. You would start now if you have not started to plan for the vaccination. It takes 6 to 9 months to put up a system in place if there are no systems in place in the country. And on the disposal of ashes, I think Professor Andy mentioned it very aptly that what has to be done. For the immunization program, the traditional point was burn and bury. You do a deep 6 feet deep dig for the 6 feet deep well and then bury it and then do it off. For the polio disposal of the polio vaccines, when we did a switch from TOPV to BOPV, we asked countries to bury the immunization. These vaccines, we wanted them to either cement them or do a chlorine disinfectant and then send it to the incinerator, and the ashes would go to the landfill slide, as Professor Andy mentioned. So I don't know if this is helpful, but I just thought I should mention this. Thank you.
Okay,
Yeah,
I think the question there was what advice to the public for disposal of PPE such as masks. And yes, there is advice to the public. There are infographics, there are charts available in multiple language, how to dispose of your mask and gloves at home. That information is available, it's online. We'll try and provide you the links after the webinar.
Okay. I think we need to move to the next section, but there are just a couple of questions. So maybe I'll just quickly, touch upon them. I think one is probably there's no easy answer to it, and that is how do you manage with the volume of waste generated when within mass vaccination if the existing systems do not support or are able to manage. So I think yes. But somewhere, we have to create that prioritization of, and we have to sort of work overtime. But if there's any other easier or maybe answer, Professor Andy or Dr. Sudhir?
If I want to start and then I leave Dr. Andy to continue on that, maybe I should start. The point is, yes, large volume of waste will be generated, but that will not be generated in one day. And immunization programs are tuned to vaccinate at least 100 to 125 people per day. So every session people vaccinated will be around the range of 100 to 125 maximum. So that is the amount of waste that will be generated per day per site. So they should be able to manage that waste. If they cannot, there should be plans in place. There should be an assessment. That is why we talked about assessment that has to be done. Yes, huge volumes of waste will be generated, but they are not generated in one place and they are not generated in one day. It is in piecemeals. I would not say piecemeal, but it's in different phases, So the most important thing is sometimes you may have to store some of this waste for the when there is an adverse event following immunization. You'll have to store those vaccine vials because then those vials will have to be investigated. So then the problem can come if a large number of volumes will have to be stored. Otherwise, if the disposal is done on a regular basis, yes, the volume is a bit bigger than the routine program, and it's for a limited number of days in routine program, but then it's not that very big that we're thinking, because we're still talking about an upper limit every day, 125 people per session site. Thank you, and over to you.
Yeah, Dr. Sudhir, I think that's an important point. Plus, I think what you also mentioned is that, the importance of safely storing and transporting these. So we must have, even if we don't have the incinerators to handle very large volumes of COVID vaccines and other items at the same time, we should at least make arrangements so that they can be safely transported, sorted, and stored. And so when the equipment is available, we can do the disposal. And I think before we go, there was just one last question, which was, is there any other method recommended, a disposable method other than incineration?
Yes, there are many methods, but the incineration is the most commonly and most preferred method of disposal. There are a number of other methods, and Professor Andy mentioned about some of those. We could autoclave, we could also do a chemical disinfect. Either it's a heat treatment or a chemical disinfectant. When we do a heat treatment, it's basically incineration, but there are other methods of heat treatment. And chemical disinfectant, basically using a number of different chemicals. Most of the time it's chlorine. But then the preferred one for immunization program is still incineration. Thank you.
Thank you. With that, we will move to the next session. And while we tackle and basically we speed up the vaccination and we handle waste from the COVID vaccination program, we cannot also, at the same time stop the control, testing, the diagnostics, the treatment. That will also continue for some time to come. So the next session, we focus on general health commodity wastes coming from vaccine, especially from the COVID programs, especially the non-vaccine waste. And I request Professor Andy to take us through his presentation.
Okay, Sachin, we just check audio and sound is good.
Yes, please go ahead.
Okay, so in now to non-vaccine health product waste disposal in the era of COVID. So really, why is there an issue? You've all been undertaking healthcare waste management for decades. Why is there an issue just now because of COVID? And I think it's important to understand the two key reasons as we go through. Firstly, most countries have actually not been managing healthcare waste very well. We could even argue there's very little management been going on at all. It's been an area which has been sorely neglected and chronically underfunded for years. Coupled with that, COVID has brought about a massive increase in the volume of healthcare waste. If we look at the example from Wuhan in China, 6 times more waste during the COVID outbreak period. So a poor management background and then a massive increase in the volume of waste during COVID. But why am I talking about this now? COVID's been with us for over a year. Most countries have managed to cope with their healthcare waste issues. They've used the private sector, they've used items like cement kilns, secure landfill sites, and so on to cope with the situation. And that's true. Most countries have coped with the increase in the volume of the healthcare waste. The problem is we're only just coping. We have to understand that the volumes from COVID will reduce as we go forward and the vaccination programs successfully reduce rates, but they're not going back to the levels that they were at before. There is now, as the politicians are wont to say, a new normal. And that new normal is increased quantities of healthcare waste for the foreseeable future. It's not enough to cope. We have to start taking healthcare waste seriously and managing that process, because it's not going to get back to the way it was. If we look at the status of healthcare waste management in Southeast Asia, we have the WHO report from 2017, and it's not very good reading. We find that policies were sometimes there, but even the most basic practice of segregating healthcare waste wasn't always adhered to. Many hospitals were just dumping the waste or trying to just burn it in low temperature. We can't call them incinerators, we have to call them burning pits. They weren't following their own guidelines for storage of the commodities in secure rooms. It was a mess. Our overall management of the situation before COVID was very poor. Why is there such a problem on healthcare waste management? Part of it is that the environmental protection authorities' perspectives don't really cover healthcare waste, and it's difficult to interpret them in relation to healthcare waste. They're not really applicable. Healthcare waste, as Dr. Sudhir mentioned, is little bits from a large number of points all over the country, often small amounts in small rural areas. The EPA regulations and the environmental safeguards weren't really set up for that kind of situation. So how we interpret them is a problem. And there's a huge variation in the way we interpret those regulations. What does it mean for us? It means that the waste management products that we have are difficult to categorize within the environmental regulations. We have to have much better environmental regulations which are specific for healthcare commodities. In the USA, they have embarked on a massive program to reform their Environmental Protection Agency regulations so as to make them appropriate for healthcare waste. The basic problem we've got is not many environmental protection people have been trained in medicine, and not many healthcare people have been trained in environmental waste. And we have to somehow have cross-cutting correspondence and communication to get together what is a reasonable risk. Often, I believe, the risk has been overestimated on healthcare waste, and we're going overboard to meet environmental regulations which don't really apply to the circumstances that we have. But why has it been such a problem? Fundamentally, because of a lack of commitment. Nobody wants to be in charge. Nobody wants to fund it. Nobody wants to allocate resources to waste. I would say it's a Cinderella, but I think it's below Cinderella. It's not considered as real healthcare practice. Nobody wants to do it, and nobody wants to allocate budgets for healthcare waste, particularly when healthcare budgets are already grossly stretched and there's lots of competition. within them for all the different aspects of healthcare. And finally, there's a lack of knowledge. And I'm sorry to say, there is a huge amount of misconception and emotion involved in waste management. And we have to take that out. And we have to get back to reality, evidence-based activities, and financial reality. What is economically sensible to undertake? If we look at the impact of COVID, it's many ways, it's increased the amount of infectious waste. It's increased the interruptions because domestic waste collection has been interrupted, and that's a large part of our healthcare waste management. There's been improper waste management taking place because we couldn't cope with the volume sometimes. Generally, recycling activities have been suspended because of lockdowns, because of restrictions around COVID. And we just haven't had the capacity to deal with all the extra generated by the COVID pandemic. But two parts directly from that and the interruptions that COVID has caused to transport, storage, and other activities. If we look at the scale of activities, and these figures are from Asian Development Bank estimates, and we look at the major cities in Southeast Asia, we're looking at a 500% increase in the volume of healthcare waste. Around 300 tons per day in the larger urban areas. Massive amounts to handle. And this is published from the UN report. The references are on the screen. 500% more waste. What does this mean? It means that for our general healthcare waste commodities, the techniques we've been using, which were entirely appropriate for low volume waste, and they're still appropriate for low volume waste. If we've got low volume from vaccination or from pharmaceutical waste, we can still use these techniques. But for the larger, particularly PPE healthcare waste, we can't use simple burning, open landfills, encapsulations, and we've got to control storage times. We can't use those techniques anymore for the large volumes. Again, they're still okay for the small volume waste, for some vaccination materials, for some pharmaceutical waste, but not for the larger volumes, such as the PPE. Governments have made quite a lot of responses to it. 2 pages here showing from around the region, the different responses, the different guidelines. The overall feeling is that, unfortunately, those responses have been largely inadequate. Onto the second page of them, more responses there. I think somehow Indonesia got mixed in with Thailand on that survey, but you can see the UNEP survey results there and the regulations that have been put in place specifically for handling COVID commodities. Our key message is we've got to move beyond this emergency phase that we're in now. Yes, we've found ways to cope now, but we have to get better at this because it's not going back to the levels of waste that we used to have. It's always going to be more now. COVID and the impact of COVID is going to be around for several years yet, even with all the impact of the vaccination programs. So in the longer term, we've got to build a better system using the lessons that we've learned from our COVID experiences in managing these larger volumes. My key message around this is quite strong, and that is to get real. And I say that because there is so much misinformation. There are so many myths and frankly, utter nonsense talked about waste management, which surround the whole subject. And we have to get to evidence-based management approaches using realistic risk management assessments. We've got to get better regulations which are specific for healthcare waste rather than looking at industrial waste. And we have to acquire the knowledge and skills. Dr. Sudhi mentioned he tried to get 3 days into around 40 minutes. I'm trying to get 5 days into around 30 minutes of managing healthcare waste. We've got to debunk these myths and get to the evidence-based. And as I go through, there'll be links to that evidence. First question is, okay, how much waste do you have? In most countries, the answer is, we don't know. How much waste do you generate per day? And most countries don't know. Well, what's happening in the private sector? Perhaps they measure it better. Not really, they don't know either. What are the hospitals and clinics actually doing with their waste? Maybe there are national regulations, but what are they actually doing? Well, there are a few guidelines to help you estimate waste volumes. Here's a guideline from Asian Development Bank for Colvid to help you estimate the increase in tonnage over time based on the number of infected people in the hospitals, in the clinics. Simple formula, very crude, but it will help with at least some estimate of the volumes of waste that you're likely to have. Average rates by facilities are given here for the Southeast Asia region, and you can see per country. Of course, per country depends on population and also economic level. So although India has a far larger population than Japan, Japan has a higher economic level and you get more waste generated at higher economic levels. But at least there's some guidelines there for how much waste you can expect to handle, and that helps us to start formulating an overall policy for the country. How much is hazardous waste? Generally, only about 15% of healthcare waste is hazardous. It varies between countries a little bit, but as a crude figure, 15%. That means that 85% by volume of our waste is non-hazardous. And after perhaps a little treatment, it can go to domestic waste disposal. The key feature here is to segregate waste into hazardous and non-hazardous waste and recognize that the majority of it is going to be non-hazardous, which can go to normal domestic waste management disposal routes. So the key around this is segregation, and the segregation must occur at source. From vaccination, we've talked about having disposal boxes right there at source. Yes. But we need to separate across every generation activity and keep that separation absolute. And that means training staff in undertaking that, recognizing and handling each category of waste separately, and having all the materials in place to undertake that. Sounds very simple, but we're not doing it. If we look at the survey of practices for healthcare waste, we find there's actually a lot of regulations already there in countries on segregating waste. But during the 2017 survey, the actual segregation went from 30 to 100%. Sometimes only 30% of the waste was being segregated. That means we're producing far more waste, which we are labeling as hazardous waste and having to spend expense and trouble to treat when it's not really hazardous waste and it could go to domestic disposal. This segregation is a key area, and yet we're not doing it so well. So we have to formulate a better response for the future, recognizing that our healthcare waste disposal in the past has not been that good. And again, it must be evidence-based for recovery, but also building back better, clear policies based on evidence. And that really brings us to incinerators, because the whole issue of incinerators is surrounded by emotion and myth and very little reference to evidence. Most places, most hospitals, most countries will tell you if we just had an incinerator, it would solve all our waste problems. No, it won't. It sounds like I am anti-incinerator, and I'm not. Incinerators can form a vital part of your waste disposal strategy, but only if you have full management and they are in proportion to the scale of the waste being generated. Too often, they've been bought or donated without consideration of the reality of the situation. They're too large because they're often based on bed capacity from Western European or North American hospitals. So they'll say this incinerator is large enough for a 300-bed hospital. In lower income countries, it would probably handle 2,000 to 3,000 beds. So it's far too large, far too expensive to operate for the situation in which it's in. And if we look at the situation around Southeast Asia, our experience on incinerators has not been that good. If we look at the Ebola response, where lots of incinerators were provided, most of them never used. They're just too expensive to operate. If we look at an alternative, which is the De Montfort low-cost incinerator, this was designed at De Montfort University in the UK. It only costs about $1,000 to construct it. It will provide a temperature of 800 degrees centigrade, so it meets the basic environmental regulations, not the full ones, but at least the basic ones. So this ought to have been a fantastic success story. Really simple to build, clear plans, basic materials available in most countries. You can even operate it on the waste packing material, and it will achieve a temperature of 800 centigrade. The reality is they've been a failure. Most of them are not in use. The ones that are in use are hugely polluting and not working. The situation is the problem is not and never has been the equipment, the infrastructure. The problem is always the management, because there was no waste management budget. Nobody was in charge. Nobody took responsibility. We tried to operate them with just unskilled laborers, with no training, and just short-term assignments. It doesn't work. My key message is it's not the equipment, it's the management that makes waste management operational and effective. What is the alternative? There are many alternatives. The report on the screen, Healthcare Waste in Asia, provides a whole section of alternatives. And again, I'm not against incinerators. Incinerators can be and they can work. What I say is follow the recommendations, clear the mind of incinerator, must have, almost this addiction to must have an incinerator. No, assess the situation and see what is appropriate to your circumstances and what makes economic and evidence-based sense. So it is management, not technology, that's the problem. Within our region, there's a huge diversity. There's no one-size-fits-all solution. It's not just one approach. It will vary according to the economic level, according to the mix. If we take a country as large as Indonesia, there are 4 major geographic regions within Indonesia. There's the high-density urban populations, medium-density peri-urban, low-density remote highlands, high-density but very small population islands. And there's thousands of those. There's no one solution for that diversity of geographic population mixes. You have to look according to the circumstances. Waste management must be a fully inclusive system, not an amalgam of just discrete activities, just one little bit here, one little bit there. It has to be a full system. Too often we look only at the threats, not at the opportunities. There is potential cost recovery in healthcare waste management, both for recycling and also for heat recovery during burning or other activities. We need to learn to measure our waste. If not, we can't manage it. We can never manage what can't be measured. And we need to prepare our healthcare waste management system for the future. We've been hit by COVID and we coped. The next pandemic We might not be able to cope if we don't have a more resilient waste management system. What are the key areas for action? Number one, money, budgets. We must have budgets for healthcare waste management. We must have policies and legislations. Many countries have those already in the region. The implementation is low, and we must improve on the implementation of those policies. Technology. On the right, technology fact sheets. You can see from university in Thailand there's a whole pile of alternative technologies available for healthcare waste management. Worth looking through, worth reading. Don't get fixated on burning technologies. There are non-burning technologies available. See which is most appropriate for your circumstances. Around healthcare facilities, raise awareness. How many of you have undertaken any training in healthcare waste management? That has to come forward. Regular training for all staff in waste management. More information on the GOERN module on pandemic response. You will find a training module on returns, discards, and pharmaceutical waste management. And of course, Empower runs regular workshops on healthcare waste, and especially pharmaceutical waste management training. These are generally 5-day workshops. So trying to explain waste management in 30 minutes is a little bit of a challenge. Okay, I'll try and take any questions that we've got there.
Yeah. So I think there's a comment from Nezang that due to COVID-19 pandemic, anything that comes out of quarantine facilities is considered infectious, thereby increasing the volume of waste substantially. Yeah, so any thoughts on this, Professor?
Yes, it's potentially infectious. It is not potentially hazardous. It can be treated very quickly, easily, cheaply with chlorine bleach. Then it's no longer hazardous waste. There are many solutions available. Depends on the particular circumstances and the particular PPE that is coming out of quarantine situations.
Yes, Professor Andy, I think very well put. So I think goes back to your point that not everything has to be burned. So recycling and reuse are in fact very well researched and recommended actions for waste management. So definitely, where possible, they should always be explored. There's another question from Dean Patuma. It says, it seems that many countries will not be able to find enough money and resources to manage all that waste. Do you think we'll need a new international institution to fight waste of COVID-19 and to implement standard operating procedures, SOPs to manage pharmaceutical waste?
I think it's a case of advocating priorities. If you can't afford 1% for waste management, something is very wrong. Yeah? It's like saying, I can't afford to clean the hospital. Is there any hospital that would say, I can't afford to do cleaning? And waste management is in that same category. Yes, you have to, and it means advocating for it and taking it seriously. We've neglected it. We've swept it away. Nobody wants to be in charge of waste management. No clinician ever wants the job of waste management. No pharmacy wants it. No healthcare personnel ever want that job. We have to change that, make it understand, bring about the environmental aspects of it, and make this connection between healthcare and the environment so that we get meaningful regulations and standards, and we understand the importance of the environment in our healthcare.
So Professor Andy, there's a question that COVID-19 is a new pandemic that may need special waste management. So how can evidence base be used? Or how is it applicable?
It does not require special waste management. It just requires waste management. Ebola is far more infectious than COVID-19. Standard waste management procedures worked well for Ebola. Yeah? What we need to do is implement the procedures, the knowledge, the evidence we already have. The problem is not that we don't know what to do, it's that we're not doing it.
Yes.
I also received a
Yeah.
question
So if any,
on my direct message saying how can we manage the vials where there is no crusher?
I'm sorry, I didn't understand the question. How can we manage the
Vials when there is no crusher.
I don't really understand the question. I'm sorry.
Okay.
yeah, I think it's a question on related to vaccine. So maybe Professor Andy, you and Dr. Sudhir both can also answer it. The question is that if there is no crusher available, then how do you dispose
okay,
vials without crusher?
Right. Okay. Yeah. Okay. You can't crush the vials. Yeah. Yeah. Okay. Right. Then the answer is you buy a crusher. But, okay. How can you handle them? Then you have to do bury. Again, remember, for small volumes of waste, you can use the traditional techniques of bury, yeah? Of encapsulation, of inertization into concrete mixtures, into other mixtures where they are rendered inert. Those are fine for small volumes. So if you don't have a crusher, if you're away from an urban area, for example, yes, you would have to fall back on inertization, stabilization, and deep burial.
And in the chat, Dr. Sudhir has provided more details on encapsulation. So I request you all to also have a look at it. And I think for small volumes, like Professor Andy said, encapsulation. Otherwise, I think we need to just store and transport it safely to where you have crushers and where you can dispose safely, or while you can get a crusher and then basically proceed for safe waste disposal. There's a question from Dr. Samir. We are on the process of phasing out incinerators. In such situation, if we consider incinerators in any way, the hospital managers, public will take it as easy way for waste disposal, etc., and will create more and more problem. So would you explain techniques to address it?
Well, if you're going to phase out incinerators, fair enough, then you're going to use another technique. And you might be using microwave technique for sterilization or any of the other techniques available for sterilization. It really is a program of education. The problem around incinerators is no one ever takes charge of them. People just send it, oh, go burn it, finished. They never look at the activity. So I agree, it's a major education program to get hospital managers and the public to accept alternative waste treatments. But they are available and we keep at it. And part of it is we're trying to do too much alone. We're trying to take charge of that situation when we should be doing it jointly with the Environmental Protection Agency. EPA are in contact with the public all the time. They need to be explaining to the public what we are doing to protect the environment. We have to learn to work with them. Not easy because they don't understand healthcare and we don't generally understand environmental issues.
Okay. Thank you, Professor. I think we are coming to an end. So I'll probably take one last question and then we'll launch a poll. So do you really advise recycling medical waste, knowing the high risk of contamination and infection?
It depends what the item is. If you are wearing a clear visor, yeah, in front of the eyes, this can be recycled. It can be cleaned and recycled. If you're wearing a disposable face mask, that's much harder to recycle. So it depends on the item. Not every item can be recycled. No, of course not. But some items can. And when we say recycle, people immediately think put back into use doing the same things. No, we don't mean that. But often we can disinfect plastics. The plastic can go for recycling once it's been disinfected. It doesn't mean we're going to reuse it as a catheter, as another item in its original use, but it can go to another life if it is adequately disinfected. It is possible. And realistically, to reduce the volumes, we're going to have to learn to do it. Does not mean everything can get recycled.
Yes, okay. I think I'll just maybe a quick question. What do you think about pit burning? Is it appropriate?
Quick burning? No.
Okay.
But low temperature burning is just not effective.
Yeah.
If you're overwhelmed and have no choice, you have to do it, but try to do higher temperature burning.
Yes. And I think Dr. Sudhir's recommend. As a fallback of burning it in a drum so that you can reach higher temperatures, probably. But like you said, I think advisable that we avoid it as much as possible. Okay. I'll just launch a poll. I think there's a comment from Moses. Maybe Professor Andy, you can have a look at it while I just launch the poll in the interest of time. Okay, so everyone, we have just, we'll give you 2-3 minutes to just answer the poll questions. We have 3 questions, and I think they're clear. The first 2 questions are, we are just seeking feedback so that we can improve on these workshops and give you a better experience and better learning next time. And we would also like to know in the third question areas where you want to know more about, specifically with vaccines and vaccine supply chain. So all this feedback would be very valuable. Please take a couple of minutes, and I request you all to maybe 1 minute more and we'll close. So please go through the questions and answer them. So in questions number 2 and 3, you can select more than one choice, while in question 1, you can only select one choice. Yes, thank you. I think the comment from Moses in the chat is very true.
What can you do if you're overwhelmed? Okay. Most large cities, most large urban areas will have cement kilns. This is the system that's used throughout China. You can dispose of all the materials. Cement kilns are very high temperature, around 1,200 centigrade. They will reduce beyond ashes. And what's left can be mixed in with the cement and cast into the new motorway. So cement kilns are usually the answer for large urban areas that need to dispose of healthcare waste quickly. The problem is the cement manufacturers will want pain. Cement kilns are high energy consumers.
Okay, there's one more quick question, and this will probably have to be the last question. How do you monitor the temperature?
In the incinerator?
I would believe so, yes.
Yeah, right, okay. There's a number of techniques. Most of them are on, let's say, visual infrared techniques to measure the temperature inside. So they're pyrotechniques on monitoring the temperatures. It's quite well-established techniques. It's relatively easy to do with modern technology.
Yes, and I think the equipment incinerators which come from manufacturers, of course, have their sensors which measure the temperature quite accurately and display them. So yeah.
There's 2 important points on the incinerator: the temperature and the dwell time. So you need to be at that temperature for more than 1 second. So that's an important part, and that was the whole point of the design of this low-cost incinerator, the De Montfort incinerator. Unfortunately, the management was never there to operate them.
Okay. So we've got, so thank you, Professor Andy. So we've got about 49 responses. I'll just be closing in the next 10 seconds. Okay, it's okay. Yeah, the poll has been, okay. I'll just quickly share the results and of the poll. Okay, so it has, most of you have found it very useful or excellent. So we really thank you. and we would want to, provide more value as well in the coming webinars. In terms of topics, I think a lot of people, many of the topics are of great interest, so that's good. We will try to see how we can cover them either through our portal, through a course, of course, covers a lot of them, and then also through future webinars. So I can see that forecasting is of interest, and I think the most more in-depth knowledge in waste management. So I think that's shows that we have had some impact in terms of generating interest and awareness. And I think it was a hard-hitting presentation by both Professor Andy and Dr. Sudhir. And I think the importance has been felt by everyone. And definitely, I think after this webinar, we all have a changed attitude and awareness. So with that, I will just close this poll. Thank you very much, everyone. And I will request Dr. Hyun to provide his closing remarks. Dr. Hyun.
Yeah, thank you, Dr. Section. Just, as a closing remarks, I would like to thank Dr. Sudhir and then Professor Andy for their presentations. From Dr. Sudhir's presentations, quickly summarizing that the presentation was he provided very insightful information on COVID-19 vaccines development landscape, as well as COVID-19 vaccines allocation from the COVAX facilities, as well as from the vaccines allocations from either from donations or the bilateral agreements between the for the CR countries and with the donors. And he also updated in the presentations the current vaccine deployment and vaccination status in the regions, which give us a kind of very clear pictures on um, on where the countries are as of today in terms of target populations, total persons vaccinated with one dose or two doses, etc. And he also provided the immunizations, the waste management part. He took us through the various processes of the waste management, as well as on the setting up the waste management plan at the national level. Professor Andy's presentation also has provided very insightful and very informative, informations on the waste management of the healthcare commodities. With the situation status of the healthcare waste management before COVID and then also during the COVID pandemic response. That was very informative. And he also highlighted some of the waste management methods that have existed before, but may not be suitable for large volumes of the healthcare waste management, especially during the global pandemic times. He also highlighted that the key problem is the management and not the technology. And also he proposed the key areas of actions in terms of budgetary, technological, and knowledge management. So all these two presentations were really helpful for us in enlightening us in terms of handling the waste management related to the vaccines and then the healthcare commodities during this COVID-19 pandemics. Before I close the webinar, I would like to announce to you that WHO CRO, along with the Empower School of Health and GON, has launched the Emergency Outbreak Response Platform, an online platform, learning platform that will strengthen the capacity of the public health supply chain professionals. So I would like to request also Mr. Section to put up the link of this emergency outbreak response platform in the chat box so that everyone can actually access it. The platform actually offers the free online courses on the procurement supply management, mentorship, resources. It also shares the community practice and collaborations, which will allow you to easily access peers, national and international mentors, as I mentioned, the free online courses, and access to any type of the resources that will be available related to the PSM. So the emergency outbreak response platform is accessible and available to everyone. It's free of cost. And the link is shared with you. As I mentioned, it will be shared with you with by Mr. Section in the chat box. And I would like to encourage you to enroll to the platform and benefit from the available free online courses and the materials available there. So please feel free to share with your peers, counterparts, colleagues about the platform. And lastly, but not the least, I'd like to thank all the participants and the facilitators, I think, for this very informative and then very interactive sessions on the waste management of COVID commodities. And we look forward to organizing regular such sessions in the futures, and also look forward for your continuous and proactive participation. Thank you so much and have a nice day.
Thank you, Dr. Hyun. Thank you to all the facilitators, Professor Andy, Dr. Sudhir. Thank you all participants, and thank you to my colleagues Namrata, Samriddhi, Hitesh, Soumya, Sonia, Preksha, and thanks to all the once again, thanks to all our participants. Have a good day. Bye.